these lives by targeted treatments. And that was actually the beginning of the bladder register, that we thought, well, we have to collect tissues from the patients, we have to collect urine, we have to collect all the data. Any patient who comes in, even if it's a PTA tumor, will be analyzed by these molecular systems. And then we gather large groups. Actually, we envision that we have at about 2,000 patients per year in the bladder register. We started initiating the second sites and the third and fourth sites in December last year. Now we have 500 patients in there. And but what do we collect? We collect clinical data, epidemiology, child's and comorbidity index, when neoadjuvant treatment, anything is being done, it's collected. The follow-up. We have the histology, the sample type, T&M stage, grade, histology. We do histopathology, we do the IHC subtypes, we do cytopathology. We do all that is possible with these patients, with these tumors, to really get a deep insight about frequency and of treatments and also molecular alterations. And this is we do subtyping, we look for hormone receptors, and of course FGF receptor 3 is part of it. In the urine, we have the Uromonitor test, which we investigate in one of the centers now, prospectively, and we might even go into more detail in this large trial. We collect the data in the new IT tool, actually, so all the investigators can type in, even the patients give in information, and everything is collected in a pseudonymized manner for analysis. So we have patients giving their patient-reported outcomes. How do they feel? How do they perform? What is the side effects, so that we get also their impact, and why don't they do BCG treatment? Why did they refuse this or that treatment? And we get all this information to really see what is being done in bladder cancer in real world. Because if you look at the guidelines and what is being done, only 50% of the guideline treatments are being done. As an example, in Germany, in the muscle invasive situation, normally you would do neoadjuvant chemotherapy, but it's only being done in 5%. 5% of the patients who should receive it, and only 20% are even informed that there's a neoadjuvant treatment. You can see reality and guidelines are sometimes in distinct corners of the same room. But I think we have to understand, why is it like this before we to be in the position to make a change. And these are the forms that we do collect the data from the clinical sites and the pathologies. They type it in, and it's in the system. And this is the way we collect the data from the patients. Even we are thinking now about wearables, meaning some smart watches, which will also give you some activity checks for certain patients. So everything in this collected from these patients, 2,000 patients per year, 5 years. These are 10,000 patients at the end where we have all the data, and they have molecular characterized patients which could be treated in case they suffer some kind of recurrence or come into some troubles, as the patient I've shown you before. However, with regard to the Uromonitor, I think it's a very good tool to also include into this clinical trial because of the superiority of cytology. We're doing cytology, but we will show that it's indeed also in this real-world scenario superior, and to detect non-muscle invasive bladder cancer. And of course, it's a non-invasive method to prevent invasive diagnostic treatment approaches. We will see how it is adopted, and we will see how this may change also the treatment. And we can look at the costs afterwards to show the cost effectiveness, and this is also very important if you want to come into the guidelines or really make a change. You have to show that it's really beneficial also for the economics. And I think this is also the opportunity for Uromonitor as being part of the bladder register clinical trial, because this is a prospective validation, including also safety of this approach by follow-up checkups. You know, we have also follow-up, and then you can see whether it really performs equally, and it's not inferior, and nothing happens if you do just urine and not to biopsy at certain frequencies. So it's a demonstration of cost effectiveness in a real-world scenario. It's a multi-center health economic evaluation even in a EU scenario. And this is something we really need to make it, to place it in the guidelines, and to also get the money later on from the insurance companies, I think. And so it's, I think the way we started, I've shown you the first data, which are very promising. I'll show you the complexity and the comprehensiveness of this database, which will be fruitful for patients, medical doctors, for Stratify, for Uromonitor, for many people, I think, because we generate a new knowledge basis for bladder cancer in the real world scenario. And the last picture, so I was talking, I've founded 3 oncological organizations. All of them had something to do with bridges. So this is the bladder register. And now I had the pleasure yesterday to be in Porto, and we went along. And so this is another bridge, a new bridge, where I was yesterday. And thanks so much for the invitation and for your time. And I'm looking forward to the questions that may arise. And yeah, that's me in Porto. And I'm looking forward to come once or twice or many times more to this great group of Uromonitor in Porto. Thanks so much.
Thank you so much. Thank you, Prof. So the floor is open for questions. I don't know if there's questions online. There are?
No, not yet. Not yet.
Okay.
But I have.
Okay. So who has some questions?
Ralph.
Thank you. Ralph, Uromonitor integrates FGFR testing of 2 hotspot mutations. Given your experience with more extensive series, would it be interesting to add any mutations to FGFR, since these are not the only ones that make patients eligible? That is one question. And another more provocative, since we also test KRAS, would you see the same rationale happening for the KRAS mutation-specific inhibitor for the G12C mutation? Would this be feasible? The prevalence is much lower, but in theory, there are also patients that could be selected for KRAS therapy.
Great questions. Yes, of course, there are some additional mutations of lower frequency which we will miss with Uromonitor. It's a Y373, for example, which has some frequency. Of course, that's the point, right? But I think it's also a cost-effectiveness issue. But however, as I've shown here, for example, in this cohort, we will look at it in a larger context, how frequencies might happen. I think you lose some percentage, some minor percentage, but at the end, the effort to do such a clinical trial, to have the screening, you win 20% of patients, and you may lose 3%. So on the bottom line, I think you're in the plus, you're on the good side. There's also a huge discussion on fusions, which is also not tested. We have published already some papers on this issue, and there will be coming up some other papers actually, which hint or suggest that the fusions have a different biology actually. They don't have this overexpression of the FGF receptor 3, for example. They are not such a good target, perhaps. And as you can also see, the frequency is very rare. This is again about 1% of these patients. So we had really problems in this clinical trial to find any fusion. Also, we did a urine test, did NGS, and within the first 300 patients, we did find 1 patient with a fusion. And we checked all the 2 biopsies, and then we recognized that there's also a mutation in there, but there's also wild-type tumors. This was a very heterogeneous tumor, actually. So we are not sure about this one of 300 patients, whether this fusion detection was meaningful because of tumor heterogeneity. So I think, given the fact that we win 20%, on the other side, we may lose. I think Y373 would be one mutation. I think this is discussable, but all the others are too rare, so that we can cannot show these hundreds of patients we include. Given the frequency, we cannot be sure about the positive effect, because these are only 3 patients with treatment or 5 with, 5 without. This will not be significant anyhow. And therefore, I think there are reasons to argue in this direction. with a very efficient, highly sensitive, comparably cheap assay, right, which gives us 20% on the win situation. With regard to the KRAS situation, you're absolutely right. So I just focus now on the FGF receptor 3. I just wanted to point, towards precision oncology. This is also precision oncology. KRAS, there are some mutation-specific mutation-specific inhibitors now on the market, and I think this is totally right. You can do pretty much the same, and then not only, of course, in bladder cancer, you can enlarge it and you can screen other entities. And of course, this is a urine-based test system, and you first think of bladder cancer, but actually we have started already activities in prostate cancer and some other cancer entities. We think that urine is a good liquid biopsy, perhaps not only for bladder cancer, but also other indications, which is something which also comes up. I think if you develop such a nice test as Uromonitor, you never know what develops out of it and how it is used at the end. Like the P16 test, which was developed for cervical cancer and is now used for head and neck cancer, determination whether radiotherapy is being done or not. So I think we have a test which has this TERT and KRAS and also FGF receptor with some major drivers, right? And this per se would be a test you could screen independent of the indication for certain targeted options, and this would be really precision oncology. But most importantly, as it is based on not on tissue, and this is perhaps I didn't mention it that good in this presentation. If you test before and under treatment, we expect that the level, if the treatment is efficient, goes down, right? So then we are on the right side. If it does not go down, we already know that we have to intensify the treatment, find some other options. So I think the Uromonitor could be used also as an early endpoint for the treatment, right? Or treatment change. So there's much more potential than just. I mean, it's a great win actually for the bladder cancer patient to have a good surveillance test, which is better than cytology. Forgive me, but I'm thinking of this precision oncology, and there I think it could be even an endpoint for clinical trials. And as soon as this comes as a companion diagnostic tool, I think it's affordable not only for Europe but also for countries perhaps outside of Europe, which cannot afford, for example, NGS testing of at multiple time points. This will be possible perhaps in the US for some very rich patients and some countries, but I think few countries will afford this. But this is a doable test with high sensitivity, and therefore I would propose to do something like this, and I do propose, and we hope we can start these adaptive trials quite soon. And the most important thing is that you have a base case. You need to show it for one cancer, for one indication. And if this works, then I would say we should enlarge this opportunity. But yeah, I think most importantly, and this is also what I learned from all the clinical trials, what you need are molecular characterized tumors, right? And if you, as a pharmaceutical company, for example, would like to treat a patient, you don't have this information because this information is not being collected in routine pathology. So we are not able to select these patients, right? You cannot do these trials. And I think these trials, for me personally, have the highest priority because there are the new options to treat, and we need to have this kind of registry to be in the position to do it all, improvements in the early situation. And as I've shown for the one case, this was progressing so fastly. I'm not sure if you do it too late, right, whether it then works. You saw how fast this tumor did develop within half a year or even a few months. Makes a huge difference when certain organs are affected, like the liver, which was a fatal incidence at the end. And we have to target the tumor before he reaches the liver, right? And therefore the T1 situation with target therapies, this exact molecular precision monitoring is really an achievement, I think.
So you are proposing that we adopt the full spectrum of the precision medicine, including monitoring during treatment. You talked about an early endpoint, but this could be performed on a regular basis to see whether treatment was at least working. And it should be interesting also to include a quantitative aspect to the test to get quantitative data on the mutation burden, maybe.
Yeah, absolutely. So I think it's also for each patient. It's a ratio, right? So dynamics of each patient. Where do we start with a FGF receptor mutation load or expression level? One could even combine it, right, in a certain fashion, and then how fast it goes down. There will be fast responders, there will be slow responders, there will be stable disease, and there will be progressive disease. And each of these need a certain adopted treatment opportunity, I think.
Do you have data about that? Do you have data about that, the decrease of the burden of mutation?
We did test it not for the FGF receptor yet. We did it in breast cancer for some other treatments, HER2 expression and mutation status. But I think it will be pretty much the same. And I think the kinetics are very important. We just recently published also, for example, a publication for lung cancer, where we did something similar, looking for CD8 positive cells in blood before and after the first cycle within 3 weeks. And if it goes up, they have a very good survival. If it doesn't go up the CD8 level, so if you have no immune induction, then you have a very bad survival.
And the burden of the mutations for non-muscle invasive bladder cancer would be high enough to see that? Because I believe with this test what you want to do is to start treatment before muscle invasive disease. So what you want to avoid is to reach the stage of systemic disease or metastatic disease, and for that we have already the treatment ongoing, so the trials. So I believe that's what you want to do, which makes sense. So my point is for non-muscle invasive disease, for bladder cancer, of course, do you think we'll have a burden of mutations that can be quantified? I mean, the decrease of the burden for, I believe that the treatment will be intravesical, not systemic, I don't know, for these patients. Do you think you can see that? Because that will be important. I mean, if what we do now is to treat the patients for high-grade disease, that's the other question. Can you correlate FGFR3 mutations with grade?
If you look, for example, at this, if you look at pure, I mean, the problem if you compare it with grade, then you have to look also at the stage, right? And you don't mix up with TA and T1 tumor, right? And there's only a very minor, this publication in the European Urology, a very minor association with the grade, much less than it's a major driver or significance, I think, for the outcome and treatment.
Okay, yeah, because the reason why you do immunotherapy, let's say, the BCG, is because it's high grade, even for TA. You know? So that will be interesting to see if the FGFR is correlated, or presence of the mutation, and even the burden of the mutations is correlated with the grade as well. Because I think as a clinician, of course not as a scientist, what we have to think is, if we want to put this on the market, we always have to correlate what is established. What's established is you do immunotherapy for high-grade disease, or in this case, meaning that T1, of course, but some TAs with high grade, you should do BCG as well. So it would be interesting to look at this. The other question is, and you talked about the NGS. Can you correlate the FGFR with the new, let's call it new molecular pathology classification that we have for muscle invasive? Meaning that, can you classify luminal papular or non-neuroendocrine? I don't know if you can.
Yes, this is something which we do. We have also some publications out there, but we do also PCR technologies, not an NGS-based approach. Fewer genes, more prognostic. We have published, for example, we divided in luminal and non-luminal tumors, and based on the keratin 20 expression, for example, and this single marker outperforms the WHO rating 1973 in the non-muscle invasive status. If you look in the muscle invasive status, you can also distinguish between luminal and non-luminal tumors, and actually in contrast to some former initial publications on new NGS technologies in small cohorts or even greater cohorts, they have multiple subtypes which lack clinical significance because they are not prognostic anymore. But we did it in these large cohorts, even with few genes, and keratin 20, for example, is prognostic, bad prognosis marker not only in non-muscle invasive bladder cancer, but also in muscle invasive bladder cancer in Germany, because they don't do that often chemotherapy and non-neoadjuvant chemotherapy at all. Now there's some work coming up, and we will publish this also, that the keratin 20 are the responders to, we have one publication out already, so this bad prognosis group of keratin 20 muscle invasive bladder cancer, which appears FGF receptor overexpression and mutation, so the parts of them have this mutation, right? They have a bad prognosis if they are not treated. They are not treated with chemotherapy. If they are treated with chemotherapy, they have responders, and the best is if you then add up after neoadjuvant chemotherapy, immune therapy. In addition, I think FGF receptor, if it's a target, so we have a whole composition of new targeted options, particular for luminal tumors, which are the hardcore tumors, if I may say it like this, in bladder cancer, both in the non-muscle invasive but also muscle invasive stage.
I have a provocative question. Is if we are doing for systemic disease and FGFR3 treatment, and we have low level, decreased level or number of percentage of mutations in muscle invasive disease, eventually I don't think it's a good treatment for maybe. Why do you think we are using the GFR3 treatment for systemic disease? So, in my opinion, it would make more sense to treat the patients in the beginning, eventually, as a driver mutation. And I don't know, what do you think about this? Because you don't see a lot of mutations for muscle invasive, meaning that eventually if you use this test to decide about neoadjuvant treatment is not a good test. Eventually.
You're absolutely right. I think the fraction of the FGF receptor mutations in the muscle invasive disease is much lower, right? Only 10% also in the metastatic situation. However, if you take this 10%, not the other 90%, right, and treat them, you have this prolongation with the erdafitinib, so it's apparently active. However, and I'm totally with you, this is a very late stage, and it's always better to get them as early as possible, and I'm very happy that all the FGF receptor inhibitor companies now focus on the very early situation, which is actually unique, that they so early go to the early disease, meaning early non-muscle invasive. It's not only a future market, but I think if we can prevent, as long as they are still on the FGF receptor side, prevent that they can invade and develop further, this can really be, and also could result in a reduction of the occurrence of muscle invasive disease and progression.
Like BCG as we have today, eventually. But do you think you can start a trial in non-muscle invasive before you do it for muscle invasive?
Yes.
You think so?
There's already the first trial ongoing, this is called Doutor 2 trial, I think. But we are already planning more elaborated ways how to select the patients, also based on risk. Because I think this is very important, that you, if you do a trial in the non-muscle invasive stage, you have to show a clinical benefit, right? And therefore I think you should enrich the high-risk fraction then you can get a better power for this. And this is very statistical, I'm sorry. So, but I think you should not only look, this is FGF receptor status is one parameter, and perhaps also a risk parameter should come into the game. And I propose, for example, to use keratin 20 in the non-muscle invasive, because this is stronger than the WHO 1973 grading. It splits it into two parts. It has been published by et al. And I think we should only take the high-risk group of non-muscle invasive and treat them.
The other thing is, I don't think you look at this, is carcinoma in situ. That's the other thing that's important. So these are mainly the patients that are resistant to BCG, and would be interesting to look at, I don't know anything about molecular, about the CIS, but I think it will be interesting to check in these patients. Of course, some of the T1s and TAs, eventually T1s, not TAs, have CIS as well, but it will be interesting to look at the marker in this carcinoma in situ, because these, if you want to start a trial in non-muscle invasive to avoid treatment or the disease to progress for muscle invasive, you should look at carcinoma in situ, CIS as well. So I don't know if you have any data about this, if you looked at this histology, if you know how the marker behaves there, I don't know, but that I think will be interesting as well.
Yeah, that's a very good point actually. So this is something we will also look at if we have larger cohorts to look into the carcinoma in situ group. We have done one publication in T1 tumors, so it's always very specific when we do such an analysis. It was T1 tumors having carcinoma in situ, right? So a higher risk group. And we looked in this trial, we looked for ERP2 expression, which is actually, I come from breast cancer field, as you know. We did the first Perception trial some 20 years ago, and I'm sure it didn't. But it was first based on ERP2, and ERP2 was a prognostic factor in this subgroup of carcinoma in situ bladder cancer. There are some new drugs also around for ERP2, which was just published at ESCO, which do work quite efficiently in a very advanced breast cancer, even having lower HER2 expression level. And I think this would be ideally suited also for the carcinoma in situ. However, we will also look, of course, for the FGF receptor 3 mutation frequency in the carcinoma in this bladder register. I think at the moment the number of cases is a bit too low for statistics, but I think after the first year we will have enough patients. So if it's 1,500, we will have enough cases to analyze this.
If there's more questions, I don't want to take this.
Yeah, I would like to ask something, which is really big. Prof pretty much answered all my questions. I have just one related to the kit itself, from the development point of view. Would you think it will be a good alternative, or I don't know if it's an improvement of the kit to detect the different hotspot mutations in a single well? Would you look at that as an improvement, as an alternative? Going back to that quantitative question, what do you think about it?
So actually, I did develop some of these breast cancer tests, as you know, and I think it would be an opportunity to make the test less complex, right? Also with some mixes with the primers already in one, and also to try to do multiplexing. However, this may be also a bit tricky from a technical point and takes some time. And there are always a problem that you have some interferences, right? And to make it as robust as possible, I would rather do not a multiplex, rather keep it simple to avoid any problem and to keep the sensitivity. Although I normally really like to do technical stuff like multiplexing, but it's quite complex, and the development of such a tool would take 2-3 years, I would estimate. And I would rather try to simplify it with regard to the mixes. If you talk about the Uromonitor, it's a great test, you can use it like this. But there are some possibilities to make it a little more simple, also with the controls and stuff like this, to make it more user-friendly and less problematic, perhaps, with regard to errors by the people who pipette this stuff, right? Multiplexing is a very good thing. Perhaps it's too complex for IVD products. Although I have to say we did develop it. We did have a license for the mammotyper, which is a multiplex assay. But if I think back, I'm not sure whether I would have done it another time.
Another question?
Yeah. Very, very short. But you were talking about, other therapy options. Maybe PDL1 is also coming to the early stages, and there are other drugs coming in for other aberrations, such as PI3 kinase. So in this setting of, I would call it co-aberrations, how would it be feasible to then use combinations of treatment? So we have been all talking about directed treatment, one mutation, one treatment. If we get two mutations, should we use two treatments?
Yeah, it's a very good question, and we discussed it at ESCO in much intensive discussions, I think. However, I think if you look at bladder cancer and look, for example, at the role of nivolumab, also PD-1, PD-L1 inhibitors, right? They're very effective in the second line, right? They run into problems in the first line. Then they started to combine it in the neoadjuvant situation, and now we learned that they make a big mistake.
Yeah.
They made a big mistake because they did ignore that you need a sequence. And I always compare this a bit like with boxing. If you have an enemy somewhere, you don't take the hook, the punch right from the beginning, but you try to get him into the corner before you do the final punch, right? And they just try to do it at first. This doesn't work because the enemy is jumping around and doing something else. This didn't work, and we will see many negative trials coming up where they combine neoadjuvant chemotherapy directly with an PD-1, PD-L1. There has been a New England Journal paper last year by Jorin et al. Where they had this nivolumab treatment. They claim that nivolumab in the adjuvant situation should be, approved by anyone, right? However, if you look into this data analysis more closely, this is a subgroup analysis. People would say this is not pure statistics. But if you look into this forest plot, only patients which had a previous neoadjuvant chemotherapy did benefit from nivolumab. The other ones is at the deadline, I would say. and I think this is also the true. If you now go to the non-muscle invasive situation directly with a checkpoint inhibitor, you may have some effectiveness, maybe, but it's not the full repertoire. And I think, for example, if you combine it by first treating this FGF receptor 3 positive tumors with, for example, erdafitinib, you get them into the corner to then do checkpoint therapy. So you have to really think carefully of sequence, not repeat the problems in the muscle invasive stage. We have learned, please look at the sequence and the right combination, not only simultaneously, and don't ignore the options. So I think FGF receptor inhibitor is one way to get him into the corner, and perhaps we need then a second opportunity for the punch.
Yeah, we were just talking about this with some of my colleagues in the US, and they do immunotherapy after BCG failure, but they have recurrence in more than 40% in less than 1 year with pembro. So IV, so for non-muscle invasive. So meaning that you are right, eventually it's not a good decision at the beginning, I believe. I don't know if there's more questions or online questions. I have a methodology question. I always like to do that, and so it's not so exciting than the other questions. But what do you consider negative or a negative control for your study? Meaning that how do you get tissue from patients? I don't know if you probably choose it. I know what I will do, but I just want to know what you have done. Which patients are your patients without bladder cancer that you got tissue from?
Well, so this is a very good question. At the end, I would say, after 2 years follow-up, I would say this is a true healthy control. Because they were suspect of having bladder cancer, and maybe we just oversee something with the initial two biopsy. So it's not, if you compare this now, and we have some patients which really have some high expression of keratin 20, for example, in the urine, so high that I'm pretty sure this patient will come back to the center. This is not a true healthy control. I mean, and therefore, but it's a very good question. We now start if any molecular system, and we also do this fast tests, you know, like NMP22 and Meteostat, and if everything is negative, including the Uromonitor, including the mRNA from the urine and so on, then, and the pathology, then it may be a healthy control, and I'm totally sure after 2 years.
Okay. Because what I will do, we want to collect samples from the patients that go for prostate surgery. So because you can go there and do biopsies. So of course they have to consent that for you, but of course then you can test it as well. Because based on all your results, eventually these two that are positive for the urine marker and they were negative for the tissue, eventually are patients that eventually when you saw something, because I have this experience that looking at, so nowadays there are people that do not resect small urothelial lesions, meaning that eventually the test will be positive and your immune system in humans will destroy the lesion. You go there after, and I saw it in my clinic, and when I go there after I don't see anything. So I resist, I take photos, and 3 months or 2 months after I don't see anything. But eventually the Uromonitor will be positive. And this can be one of the reasons why you go there after you don't see anything, but the urine still have some markers or some mutation. So it can be that. So I'll do eventually to collect. I'm sorry because I like methodology. Because I was doing my things. When you do the surgery for the prostate, the TURP, you just have to ask the surgeon to say, okay, consent the patient and take some biopsies from the bladder. Of course, they have to check and guarantee there's nothing, but eventually that they are good negative controls. I'm sorry for the question, it's not very exciting.
No, it's really a great idea.
Okay, so I think we can conclude, and thank you very much. It was a pleasure. I hope you enjoyed the discussion.
It was a pleasure.
Thank you very much. Thank you all.
Thanks so much.